Good morning. I am Dr. Lisa Isaac, President of Gateway Medical Society, and it is my pleasure to welcome you to the next installment of our 2022 Virtual Community Symposium Series. On behalf of Gateway Medical Society, I extend warm greetings to all. We are so pleased that you have taken time out of your day to join us, and I'm sure you will not be disappointed. Gateway Medical Society, established in Pittsburgh in 1963, is a component of the National Medical Association. Our mission is to eradicate healthcare disparities. We conduct our mission in several ways, including, but not limited to, providing education to promote public health, raising awareness of healthcare disparities in minority and disadvantaged communities, and collaborating with other groups who have similar missions. I am pleased to announce that today we have the pleasure once again to collaborate with our incredibly supportive friends, the Pittsburgh Black Nurses in Action. The topic today is colon cancer, early detection, your cancer journey. We know this is an important topic since colorectal cancer is the third most common cancer in men and women. It is of particular importance to African Americans who suffer the highest incidence and highest mortality from this disease compared to other ethnic groups. We will learn much more about these facts and cancer in general as we move into this interesting program. We have an impressive panel featuring a stellar moderator and three very dynamic speakers. At this time, I am pleased to introduce our moderator, Dr. Lynn B. Robertson. Dr. Robertson is the Associate Director for Health Equity and Community Outreach and Engagement at UPMC Hillman Cancer Center. There, her focus is addressing health inequities within their 29-county catchment area, addressing access to care-related issues, decreasing cancer burdens, and improving health outcomes through the implementation of evidence-based interventions. She has an extensive and wide-ranging background in oncology, both clinically and administratively, and also in community-based research. Holding faculty positions in the School of Medicine, the School of Nursing, and the Graduate School of Public Health at the University of Pittsburgh. Over the last 10 years, she and her team have focused on developing community-based collaborations with a particular focus on underserved communities. She has worked to identify the needs of individual communities and then develop educational programs to meet those needs. And she has done this in very important areas such as early cancer detection, especially colorectal cancer screenings. Over the last several years, her team has worked with communities to increase awareness and screening regarding colorectal cancer among the underserved, and doing this through collaborations with GI departments to develop a successful no-charge colonoscopy program, and also making available translators and written materials for many patients who do not speak English. Through these efforts, she and her team has successfully increased colorectal cancer screening from 51% to a remarkable 79%. She is very collaborative and committed, and we are quite pleased to have her as our moderator for this important discussion. Finally, before I turn it over to the moderator, I must take a moment to thank our symposium partners, including the Heinz Endowments, UPMC, Highmark Whole Care, Pittsburgh Black Nurses in Action, Chi Eta Phi Nursing Sorority, the Faith-Based Health Collaborative, the Links Incorporated, my sisters at Alpha Kappa Alpha Sorority Incorporated, Alpha Alpha Mega Chapter, the Ivy Charitable Endowment, and anyone that has helped or will help with any part of this symposium series. We give thanks to all for making it possible. And now I'm happy to turn this program over to the capable hands of our moderator, Dr. Lynn Robertson, who will in turn introduce the other members of the panel. Dr. Robertson, take it away.
Thank you, Dr. Isaac, and thank you for the beautiful introduction. Welcome, everybody. I don't know, Tamara, if you want to start my slides, please. Thank you. While we're getting ready to see the slides, I know there are a few things that most of you that have probably joined some of the other educational programs are aware of. Next slide, please. There's some housekeeping things. Everybody's muted. Question and answers will be held until the last presenter has finished, and please put your questions in the chat box. And that the webinar is going to be recorded and will be available for future view on the Gateway Medical Society website. In addition to that, everybody that's participated today will be receiving a free FIT kit, or a colorectal cancer screening kit, in other words, in the mail very shortly, with directions on how to actually perform the stool testing. So before I go into my few slides, I would like to introduce our panel today of speakers. I'm going to start with Joanne Boyd. She is a clinical research coordinator too at UPMC Hillman Cancer Center Community Network, where she coordinates and conducts research activities for patients involved in clinical trials. She recognizes the importance of diversity among participants in clinical trials and works on initiatives to increase awareness for people of color and underserved populations regarding the value of their involvement in research. She is the recipient of the University of Pittsburgh School of Nursing's 2021 Distinguished Alumni Award for Service and a variety of other awards. She's a member of the American Case Management Association, the accrediting body for her ACM certification, and a lifetime member of the National Black Nurses Association, where she serves as the chairperson of the Health Policy Committee. So we'd like to welcome Joanne Boyd. In addition, we have as a speaker today, Dr. Stephen Evans, and he is a clinical professor of surgery and surgical oncologist whose primary practice is at UPMC Shadyside. He serves as the director of community engagement for the Department of Surgery and has dedicated a large part of his career to closing the divide and disparities in healthcare for minority populations in the Pittsburgh region. Dr. Evans is the recipient of the 2019-2020 Leo Creep MD Excellence Patient Care Award. And this award is given annually to a UPMC Hillman Cancer Center physician who has demonstrated work-related efforts that are truly above and beyond the course of normal duty and that clearly contribute to the overall quality and success of UPMC Hillman Cancer Center. He is also the winner of UPMC's Award for Commitment and Excellence of Service, or the ACES Award, in 2020. As Director of Community Engagement for the Department of Surgery, Dr. Evans served as the physician leader engaging other faculty, medical students, and residents as volunteers to administer COVID-19 vaccines to the most vulnerable populations disproportionately impacted by the pandemic, one shot at a time. And our last speaker, excuse me a second here, is Dr. Melhelm, who is a psychiatric epidemiologist and statistician in genetics. She received her PhD from the Graduate School of Public Health at the University of Pittsburgh, and her research is focused on immunobiology of stress and suicidal behavior. She is the PI on 4 R01s that are funded by the National Institute of Mental Health, and she is currently conducting the study iCares, which you'll hear more about, that involves working with children whose parents have cancer at this point in time. So I'd like to welcome all 3 of our panelists this morning. And now, if Tamara, if you would advance my next slide again, please. Colorectal cancer is the 2nd leading cause of cancer death among men and women combined in the US. You heard from Dr. Isaac a number of other things about colorectal cancer, and that's why this is so important. Colorectal cancer has also been recognized as a public health priority. Next slide, please. You can see here that it's a major public health problem, and you look at the lifetime risks. 1 in 23 men will develop colorectal cancer, 1 in 25 women. 1 in 3 adults have not been screened between the ages of 45 to 75. Why we're here today and why we do the work we do is because we don't want you or someone you love to be one of the 3 that doesn't get screened. Next slide, please. With the impact of the COVID pandemic, it really did have an impact on colorectal cancer screening, as well as other screenings. But you can see here, 90% drop in colonoscopies, an estimated 18,800 missed or delayed diagnoses, 1.7 million missed colonoscopies, and they estimate over 4,500 excess deaths over the next decade due to these drops in screening. Next slide, please. So we know that screening saves lives. That's why we're all here today. And I'm going to start off today's presentations with Dr. Steve Evans.
Thank you, Dr. Robinson. And thank you, Gateway Medical Society and Pittsburgh Black Nurses in Action for allowing me to be a part of this very important conversation. So today we're going to discuss the significance and importance of early detection and consider our patient's journey through cancer. African Americans, as stated, have higher death rates than all other racial and ethnic groups for all cancers: breast, colon, and lung cancer. Breast cancer is the most common cancer diagnosis for women. Black women are more likely to be diagnosed with a triple negative breast cancer, a more aggressive form of cancer. Black women are 40% more likely to die from breast cancer. And as it comes to colorectal cancer, as stated earlier, it is the 3rd most common cancer in men and women, and remains the 2nd leading cause of death in the United States. And colorectal cancer has a 90% cure rate if caught early. African Americans have the highest incidence of mortality from colorectal cancer and have the highest incidence of colorectal cancer at young ages. Lung cancer is another disease that impacts our community the most. It is the 2nd most common cancer in Black men and women. Black men have a higher lung cancer rate compared to white males. Lung cancer remains the leading cause of death worldwide. So today we're going to have a conversation about cancer. We often hear, as I just stated, the high incidence and disparities that occur in minoritized communities. And my question that I pose to you today is, does race really matter? Race defines a group of people based on their inherited physical features that are influenced by genes. We are all 99% identical, genetically the same. Our genes determine the way traits or conditions are passed from one generation to another. People differ due to a host of factors, including natural selection and random genetic mutations. The majorities of cancers, however, occur through random genetic mutations. Inherited mutations that you may have heard of, which include BRCA1 and 2, cause less than 5% of all breast cancers, for example. And FAP, familial adenomatous polyposis syndrome, a tumor suppressor gene mutation, occurs in less than 3% of colorectal cancers. In this condition, thousands of polyps are found to line the layer of the colon, even in patients as young as 10 years of age. So that's why we're here to talk today about the importance of screening and early detection. The goals of screening is to identify cancers early when you don't have any symptoms. The goal is to further lower death rates, identify people at a higher risk due to family history or genetic mutations. Inflammatory bowel disease, for example, such as Crohn's or ulcerative colitis, also predisposes a person to have higher risk of colorectal cancer. So what are the screening tools that we have in our toolbox? Dr. Robertson will talk later about the FIT test. It detects hemoglobin in stool with an accuracy of 93%. It costs about $20 to $50. FIT DNA test, Cologuard, some of you may have heard, looks for traces of DNA, genetic material shed by polyps or colorectal cancer, and has the accuracy of 95% and costs $500. CT colonography costs about $1,000 and should be performed every 5 years. Flexible sigmoidoscopy, which only looks at a portion of the colon, costs $800 and also should be performed every 5 years. Colonoscopy, which is the gold standard, costs $2,000 and is recommended to be performed every 10 years. So those are the tools that we have in our toolbox. But as Dr. Robinson reported, COVID-19, the greatest pandemic that we've had in 200 years, had caused screening to come to a screeching halt. It is now time to catch up with our screening to save lives. The U.S. Preventive Task Force recommends colorectal screening at age 45. 95% of all colorectal cancers can be identified in this catchment area of ages 45 to 75. Colorectal cancer incidence is higher in Blacks, American Indians, and Alaskan Natives. Why is that? As of 2018, only 65% of the eligible people have colorectal screening. It is only through intentional efforts, as stated by Dr. Robinson, that we can rise above the target of 2020, which is 74%. So it is great that with Dr. Robinson and her team's intentional efforts, they have gotten this colorectal screening rates to the upwards of 79%. So that shows that progress with intentionality can be made. Extra safety measures have been implemented since the pandemic to keep you safe. Colonoscopy remains the gold standard because it allows visualization of very tiny polyps that can be safely removed and determine the presence of cancer. So again, screening saves lives. Screening is the best tool for early detection of breast, colon, and lung cancers. And remember, the best screening test is the one that is completed. Also remember, next slide, that caring for the patient with cancer requires a multidisciplinary team. The primary care physician is the primary gatekeeper. Patient navigators, such as clinical oncologists and nurse specialists, play a vital role in guiding the patient through this maze of unknowns. Oncologists, the surgeon, pathologist, the psychiatrist, psychologist, and pastoral care team, all are vitally important to the patient's successful survival. And we further know that cancer survivor and caregiver support groups play an integral role in how the patient experiences their journey through cancer. How can we gain more information about how cancers and why, more importantly, cancers impact marginalized communities than others? Clinical trials are necessary. Next slide. To advance this information, why do Black patient populations have higher risk of colorectal cancer? More robust research is needed to address these disparities and find solutions to narrow the gaps in colorectal cancer screening and cancer outcomes. We need more patient-facing physicians and practitioners of color that include African Americans, Latinx, and Native Americans in order to encourage these populations to participate in clinical trials. Having more providers of care from culturally diverse, racial, and ethnic communities may help mitigate the fear and lack of trust in these valuable tools. Clinical trials have proven that equal care promotes equal survival. Now, let's hear more about clinical trials and their relevance and importance in advancing and mitigating disparities by Joanne Boyd.
Thank you, Dr. Evans. That was a great overview and a great segue into my talk for today. And so I'd like to share with the audience the importance of clinical trials and why it is important to consider clinical trials as a possible one of the tools that you have in your toolkit when you're looking at your cancer care journey. It would be remiss of me, however, if I didn't start that part of clinical trials when we think of the history behind research that has happened in the past. And I'm going to just wait a couple seconds here to allow Dr. Edwards to catch up with my slides. But when we think of the past and think of things that have occurred in the past, it is often those things that keep people from wanting to participate in clinical trials due to the lack of trust, because they reflect upon some of the things that were done in the past history that were not necessarily fair to people of color. Next slide, please. So I'm going to start with the Faskiki syphilis study, which is a study that's known to many in the African American community and community at large. And this was a study of untreated syphilis in about a group of 400 African American males. The study was conducted between 1932 and 1972 by government regulators. And the purpose of that study was to observe the effects of the disease when untreated. However, through the end of the study, medical advancement meant that that disease was entirely treatable. The men in the study were not informed of the nature of the experiment, and as a result, more than 100 of them died. And so we know that that was a very dark spot in our history that was not fair to African Americans and should not have been done. It was not ethical. But it did happen, and we have to learn from those mistakes of the past so that we can move forward. The next point in history that I'll share is that of the woman Henrietta Lacks. And Henrietta Lacks was a woman whose cancer cells are the source of the HeLa cell line, the first immortalized human cell line and one of the most important cell lines in medical research. The immortal cells do not die in the laboratory. They continue to reproduce indefinitely, which is why they can still be used today in advancing science. Now, if we just stop there and look at that, one might say, well, that's pretty awesome that, her cells are being used to advance science throughout the world. But however, in 1951, as the practice at that time, consent from the patient or family was not required to obtain the use of those cells. And so that meant that the family was not aware that that was being done. And even though in 1970, some of that information regarding the origins of the cells became known to research, it wasn't until 1975 that the family was actually informed of where and how her cells were being used. So if you think about this, you can say, well, the patient wasn't harmed, and technically there weren't any rules broken because it wasn't a rule to have informed consent at that time. But it certainly calls into question ethical practices and principles. Next slide, please. So moving forward, let's look at what are some of the lessons learned. We'll start by a definition of clinical trial, and I took this right from the National Cancer Institute in part. And a clinical trial is a research study done in people that helps healthcare providers understand the best approach to prevent, diagnose, treat, or manage symptoms of disease. This is including cancer. So why is that important? What is the importance of clinical trials in cancer treatments? Well, cancer diagnosis is oftentimes the start of a very difficult journey filled with many emotions. And I believe that learning more about the various treatment options and supportive care services may help to ease the burden as you, a family member or friend, journey through. Clinical trials can be used to evaluate a wide range of treatments, such as medications or surgical procedures, and to explore new ways to diagnose and prevent cancer, to help manage symptoms, and to improve the quality of life with people with cancer. Through clinical trials, new treatments and procedures can be tested by comparing them to the standard treatments and procedures. Clinical trials can help doctors and researchers know if the new treatment is safe and how it works, and if it's better than what we know as the standard of care treatment. So let's talk a little bit about the safety and ethics and how do we protect human subjects that are involved in clinical trials. Participants in clinical trials are an essential part of cancer research, and there are federal rules in place to help ensure the safety and ethics of those trials. So participants are protected through a careful review and approval of the clinical trial protocol, which is a very extensive document that researchers have to prepare in advance that outlines the whys of their research, some of the history and things that have been done in the past, what the participants can expect to happen during their course of participation in a clinical trial. And all of that information has to be reviewed by scientific experts and an institutional review board to ensure the safety of the trial to be conducted. There are also then criteria that's evaluated to determine whether a patient can be included or may need to be excluded from a participation in a clinical trial, because we want to make sure that it's the appropriate thing to do for the disease under study that involves patients. The informed consent process is another important safety factor. Clinical trials and participation, it's voluntary. And so that means that you have to give consent to decide if you want to participate in that clinical trial. The consent form then will outline all of the information that you would need to know about participating in the clinical trial, what would be expected of you, how long you might be expected to be a part of that clinical trial, some of the side effects that you might expect to see from the new drug that's being studied, and you must give consent before research can be done. And then throughout the life of the clinical trial, there's still ongoing monitoring by the IRB, and data and safety monitoring boards are also looking at the different findings that are being shown from the participation in the clinical trial. So that might be lab work, that might be different tests that are being done. All of that data has to be captured and reviewed to ensure that it's still safe for patients to participate. Sometimes organizations will sponsor a clinical trial and they will have their own rules and regulations that researchers have to abide by and answer to in terms of monitoring patients. And then the research team and your healthcare providers are constantly looking at your lab work and diagnostic test results and looking at any side effects that you might be having or other symptoms. So why consider a clinical trial? Well, like all treatment options, clinical trials have possible benefits and possible risks. So some of the benefits that you may find when you participate in a clinical trial is that you will have access to a new treatment that's not available to people outside of the trial. The research team will be watching you closely throughout the life of the clinical trial. And the treatment that's being studied may be more effective than the standard of treatment that typically occurs for the type of cancer that you have. And you may be among the first to benefit from that. There are also studies that perhaps there may not be an immediate benefit to you as a participant, but it can help researchers in terms of helping people in the future. But there are also possible risks. The new treatment may not be better than or even as good as the standard treatment. Sometimes the new treatment might have side effects that the doctors didn't expect, and they may be worse than those of the standard treatment. You may also be required to make more visits to the doctor than you would if you had been receiving standard treatment, and it may cause you extra expenses related to those extra visits, perhaps extra out-of-pocket copays, travel, housing, childcare costs, and sometimes clinical trials are just not covered by insurance. Sometimes the extra tests may be uncomfortable or time-consuming. And last but not least, even if the new treatment has a benefit in some patient, it may not work for you, which leads me to my next point of conversation. The importance of diversity and inclusion in clinical trials. So historically, and even still today, clinical trials do not always recruit participants who represented the individuals most often affected by a particular disease, condition, or behavior. The clinical trials are most often exclusively represented by white male study participants. Women, the elderly, and people of color, especially African American and Hispanic patients, are consistently unrepresented. While people of color make up about 39% of the US population, these groups represent from 2 to 16% of patients in clinical trials. While there are multiple drugs that win approval each year from regulators like the FDA, these studies that lead to their approval are often not demographically reflective of a diverse patient populations. We heard about the ethnic and genetics and gender differences that may have an impact on how effective a treatment might be among different groups of patients. There are multiple factors that influence our individual response to treatment. They could be environmental factors, perhaps if you are in an environment where you may be exposed to secondhand smoke, physical difference, physiological difference, genetics, and some things are just not known. But by taking into consideration these factors and individual differences among diverse patient populations, researchers and healthcare providers may uncover further pathways towards the delivery of personalized care. That's that type of care that is precise option for you. Next slide, please. Next slide, please. Might be a little bit of delay in advancing the last slide. So let me continue on. And I will share with you one of an examples that I'll use to talk about the importance and how different genetics may affect each of us. And one of the examples I'm going to use is that of what I call, or what is called shortly, BEN, benign ethnic neutropenia. And BEN is a condition that's observed in African Americans, and it's characterized by reduced absolute neutrophil count in the absence of secondary causes. Okay, so here we go with the slide. So in contrast to other causes of neutropenia, BEN does not increase the risk of oral or systemic infections. So let's look at that a little more closely and talk a little bit about neutrophils to help further explain that. Neutrophils are white blood cells that are in our body system, and their purpose is to help protect us from infection. They're circulating in our body and they are looking for infection, and then they want to attack that infection. So, and look at patients are receiving chemotherapy because of the mechanisms of some of the medications, they can be more at risk for developing infections because their immune system is compromised. And the neutrophils playing a role to protect us in situations from infection. That's a lab value that's very closely monitored in general with patients that are receiving chemotherapy or undergoing other types of cancer treatments, because we want to make sure that we are protecting them against infection. However, several researchers have observed that African Americans have lower pre-chemotherapy and post-chemotherapy leukocyte and neutrophil counts when they're compared to white patients. So this reduction, however, they have proposed that there are many reasons why the medications that we might want to adjust when we see a low neutrophil count and change, or sometimes maybe even cause delays in our treatment, or sometimes stop the treatment altogether. While that might be important for a white patient, it may not be the same route to take for a person of color who has a condition of Ben, where their neutrophil count might be low, but it may not warrant that type of adjustment in their treatment or medication. And that also might be a reason why there is high cancer-related mortality in African Americans, because when you're looking at how you're forming a treatment plan for them with Ben, it may be different than how you plan to treat your white patient. So a greater involvement of African American patients in clinical trials may help doctors and research to further understand Ben and its relation to cancer treatments, and ultimately further provide guidance for treatment decisions related to Ben. Next slide, please. We talked a little bit about the various multiple factors that impact how we respond to treatment. Gender is another such of those factors, and it can play a very important role. Studies in recent years have shown that the immune system plays a fundamental role in cancer evolution and response to cancer treatments, specifically immunotherapies. But there is documented distinctions between men and women. So when researchers are assessing cancer response and disease control, the results of the studies conducted in female patients may not categorically apply to male patients, and vice versa. Next slide, please. So is a clinical trial right for me? I think this slide can be summed up pretty much with the first statement being knowledge based on facts is key. So get the facts so that you can make an informed decision about treatment options that will impact your life. Some of the factors that will influence your options for clinical trial participation may include the type of cancer that you have and your overall health. Clinical trials just may not be appropriate for all patients, but it's important to discuss the treatment options with your healthcare provider. Some of the questions that you might want to ask your research team: why is the study being done? How long will the study last? Where do I go for the study treatments and tests? How often will I need to be seen by the research team? Are there other options for my treatment? And will there be additional costs associated with my participation in a clinical trial? So in summary, we continue to learn and move forward from the historical wrongs of the past. We can all play a role in the solution. Arm yourself with the knowledge to help fight off fear that often comes with a cancer diagnosis. Rely on trusted resources to get the facts. The internet is filled with a lot of information, but we want to make sure that we're going to the information that are trusted resources, and your healthcare team can help you with that. By carefully exploring all of your options, including clinical trials, you are taking an active role in decisions that affect your health. So I'd like to leave you, next slide, with one of my favorite quotes, because we want to live in a world that we are all treated equal, that we are all having access, equal access to care, and that there are equal healthcare outcomes that are good outcomes for all. And sometimes that may mean that you have to be the change you want to see in the world. So I'd now like to turn it over to Dr. Nadine Melham so she can share some information regarding her study.
Thank you, Joanne. That's a great segue to my talk that will be focused on how can we improve or do a more comprehensive job in treating the patient by looking at the cancer experience as a whole and how does it impact the full family. I'm waiting for the slides. Thank you. Next slide, please. So in 26, there were 15.5 million cancer survivors in the United States, and approximately 38.4% of people will be diagnosed with cancer at some point in their life. The number of people who are newly diagnosed with cancer is about 439 per 100,000 per year. And of these, there are 2.85 million children who live with a parent diagnosed with cancer. So this is like, these numbers are staggering numbers. We first conducted a study in melanoma because we chose melanoma because it is one of the most common types of cancer affecting young adults who had children who are young children. Next slide, please. Cancer is an experience, a stressful experience for the whole family, not just for the patient, although most often the patient is the focus in the treatment. Parental cancer is especially distressing for adolescents and young adult offspring because adolescence is a period of development that is sensitive to stress and its long-term impact. We are now conducting, when we did the pilot study in melanoma, we had some findings that were very interesting and surprising to see early on in the cancer experience that I will be talking about. However, we wanted to do, as when we submitted these findings to NIMH, we got a large study to really keep that work going and the research program going to examine biological stress responses and mental and physical health outcomes in children of parents who are recently diagnosed with parents. And that is the iCare study that I will be talking about. In the iCare study, we have 33 children of parents recently diagnosed with cancer and 26 children from families without cancer or severe chronic illness in parents and siblings. We have now recruited a lot more than these numbers, but these are the numbers that come from the pilot study. At the time when we focus on the melanoma and skin cancers in the pilot study, 97% of the patients were Caucasians. And that's where we wanted to do better in the iCare study to include more minoritized populations, specifically African American, where, as Dr. Evans mentioned, colorectal cancer has a high incidence in African American young adults who often have children that are dependent children. We had in the pilot study, 70% of children had a parent diagnosed at stages 3 or 4, although we include patients at all stages of cancer. Patients and their families were followed for 1 year after cancer diagnosis. Next slide, please. We looked at how did the kids perceive the stress and their worries about cancer. So when we compare the cancer group to the controls, who are children and offspring of parents who don't have a parental cancer diagnosis or any other chronic illness. So the purple is the cancer group and the green color is for the controls. So if we look at intake, when they first came into the study, which was about within 6 months of the parental cancer experience, we find that the children in the cancer group, they experienced more perceived stress. That continued to be the case at 6 and 9 months later. And that was statistically significant. Next, please. When we asked them about their worries, because the perceived stress is stress in general, but we wanted to ask about worries specifically related to cancer, we found that the kids were worried about cancer, specifically affecting themselves, affecting other family members and relatives at intake 6 and 9 months later. Next slide. We also looked at some of the psychiatric symptoms that children are facing. And this is, we're talking about kids who are within 6 months of the parental cancer diagnosis. So this is a very recent timeline, because most of the studies that are in the literature, they look at offspring or children who have experienced cancer, or adults who had experienced a parent with cancer a long time ago. So we really cannot tie whether their psychiatric consequences are really related to the cancer diagnosis, but this is within 6 months of the diagnosis. Next, please. We find that the children of parents with cancer who are living with cancer, they experience or they reported more depressive symptoms at every time point of the study. And they also experience more anxiety symptoms at every point in the study as well. We also looked at physical outcomes, and we're looking at obesity and sleep in kids of parents recently diagnosed with cancer. What we found is that there is a slight increase that is starting to happen in body mass index in the children of parents diagnosed with cancer. And that reflects probably some of the stressors that happen in a family when a parent is diagnosed with cancer, and monitoring the kids' eating and eating habits and choices may be difficult during the cancer experience. We also looked at sleep, and we found that sleep was deteriorating, and the quality of sleep was deteriorating in the children of parents recently diagnosed with cancer at intake 6 months later and 9 months after the baseline assessment. We also looked at the biological stress responses, and the question is, how does a parent living with cancer and the stress of living with a parent with cancer affect our biology? Because our hypothesis is that all of these psychiatric and health outcomes, they are really occurring through the impact of the cancer or the stress of a parental cancer diagnosis on biological responses. So we looked at next please. We looked at hair cortisol concentrations, and hair cortisol is a very interesting tissue hair, because in everyone, hair grows about 1 centimeter segment per month. And the 1 centimeter segment that grows reflects or captures cortisol levels, which is a hormone. Cortisol is a hormone that is a marker of stress. And it does capture it for the month that was prior. So if we take 3 centimeter segments from people today, it will reflect their cortisol concentrations for the past 3 months. So what we found that the offspring early on, they showed high hair cortisol concentrations. However, over time, there is a reduction in hair cortisol concentrations. And this is very important because cortisol and the HPA, the hypothalamic pituitary adrenal axis, which is one of our most important stress response biological systems, it is adaptive to produce cortisol when exposed to stress. However, when the experience or the stressor is chronic, it may result in dysregulations in the HPA axis and in biological systems. So what we're seeing is that despite the fact that these kids are living through a stressful experience, they're not producing as much cortisol at 6 months compared to the control group. And that is an evidence of a downregulation of the system. We also found IL-1 beta messenger RNA, which is a marker of inflammation, to be increased in the offspring of parents living with cancer at intake and 6 months later. We also looked at depression and anxiety symptoms of the parent with cancer, because the outcome of the parent and the treatments of the parent and the side effects that the parent live with would impact the outcome of their kids. So what we found is that the beginning of the cancer diagnosis, there was an increase in depression symptoms in the parent with cancer. However, that was decreased 6 months later, and that is great news. And that speaks to the attention and the clinical attention that the patient gets and the comprehensive care that they get from not just treating the cancer, but treating the psychiatric consequences of cancer in the patient. We also found that the anxiety symptoms in the parent with cancer also decreased over time. When looking at the caregiving parent, we found that similar to the offspring, depression symptoms increased over time. And similarly, anxiety symptoms were high at intake and they continued to be high at 6 months. So in conclusion, we are showing evidence from the pilot work that biological and psychological stress responses, they do happen early on following parental cancer diagnosis. Children and caregivers, they do continue to show increased depression and anxiety symptoms over time following the stressful cancer experience in the family. Also, what we found is that the children's perception of the severity of their parents' cancer diagnosis was associated with poor outcomes. I did not present this, but we did ask the children about how much they think their parents' diagnosis, like the severity of their parent cancer diagnosis, because we didn't want to disclose any information about the stage or the cancer diagnosis. The child had to know about their parents' cancer diagnosis, but this was a question to try to assess how much the child knows details and perceives the severity of their cancer. When we looked at that, the children's perception were not related to the outcome, which really speaks to the fact that the cancer experience in a parent is stressful to children regardless of the stage and regardless of the severity of their cancer. Next, please. So I would like to let you know that the iCare study is still ongoing. We are now capturing more children and families, not just in melanoma and skin cancers, but at all types of cancer and all stages of cancer. We have not had many minoritized populations in the study, and we hope that more and more patients from African American community would participate in this study, because we do want to capture their experience and how the experience of cancer in a parent affect the whole family. We are looking for children and offspring who are 10 to 21 years of age who have a parent with cancer, and we are very flexible in really doing the study at patients' home and make it as easy as possible, because we do understand how stressful the experience of parental cancer is on the children and the families. And we go to patients' homes, we do Zoom interviews, and we make it as easy as possible. If you are interested in participating, please contact us, and we have our website, icare.pit.edu. Thank you so much. I introduce now or give the podium to Dr. Robertson.
Thank you, Nadine. These presentations have been very informative this morning. It's a wealth of information, and keep in mind, sometimes I know I personally have to go back over things. And so this is recorded and will be on the Gateway Medical Society website. So prior to taking questions, I'd like to go over the fit kit procedure that you're going to be receiving in the mail. If you could show my slides, please. Okay. Oops. I think we need to go back up here. Could you, whoop. Okay, as you've heard today, we know that screening saves lives, and the best type of screening that is done is the one that people do and comply with. Next slide, please. So this is the kit that you'll be receiving in the mail. It's called an Insure One kit, and you'll not be receiving the box. You'll be receiving the envelope that's on the right-hand side. Within that envelope will be a test card, a packet that you'll have to open up, and it'll have 2 sampling brushes and 2 blue waste disposable bags, instructions, a requisition form, sorry for the typo there, and the requisition form is going to have a label on it, and That label is very important because that's information that allows those results to come back to me. And also that label allows that you will not be charged for this test. And also you'll have a yellow return envelope that is already postmarked in the kit. Next slide, please. So as you can see here, in getting ready, what I usually ask people to do is please read the instructions. If you have any questions, you're going to receive my phone number also. So you can call me if you do have questions at any time. There is no special food restrictions or medication restrictions for this test. What you do need to do, though, if you have cleaners or bluing agents in your toilet, to remove those. I always encourage people to flush their toilet twice prior to beginning. And you can do this test at any time of the day. It doesn't matter, whenever you have a bowel movement. You don't want to do the test, though, if you have bleeding hemorrhoids, if you notice blood in your urine or blood in the toilet. And if you do notice that, you really should contact your doctor. And if you don't have one, then you should make a contact to somebody. Even if you call my number, I will facilitate getting you in touch with someone that you can talk to. If women should not do the test 3 days before or after their menstrual cycle. And I've seen this firsthand. If you have bleeding cuts on your hand, don't do the test because you'll get a false positive. And if you have toilet water that uses salt water, sometimes this will alter the test results also. Next slide, please. So what you need to do is, as I said, open up the kit, read the instructions. You'll have your blue bag there, which is just to throw the rubbish in, and flush your toilet twice, have your bowel movement, and you'll have a test card. And the test card has a flap on the back and it says open. You open up that flap and you can see on your right-hand side that the card has two little squares. So after you've had your bowel movement, you want to take one of the brushes and just lightly brush over the stool, very, very lightly. It's more of a toilet water test than a stool test. And I can honestly tell you, if there's clumps of stool on that card, they will not process it. So you want to lightly brush the surface of the stool, tap the brush so that you get any excess water, etc., off of it, and just lightly brush the surface of the first square. Get rid of that brush, take your second brush, repeat the test or repeat the process, and use the second square to brush lightly. Close the flap, and you have on the form, the requisition form, there's a label. Next slide, please. And generally, I tell people to fill this out ahead of doing the test. It will ask for your name, your date of birth, and the sample date. Fill that label out, and that goes over that flap, so it keeps it down once the test is done. If this label is not filled out, they will not process the test. So the lab will just tell me they did not process it. You want to take that card, the requisition, next slide, please, and put it in the yellow envelope. Seal the yellow envelope, and I encourage people, if they can, to put it in the mail the same day or at least by the next day. There is like a 10-day window here for the test to leave the mailbox, the post office, and get to Quest Labs to be processed. If it is over 10 days, often they'll ask that the test be repeated. The results come directly to me. They are secure. They come into a locked office on a fax machine. So there, is no way that someone else is going to see your results. And then myself or a member of my team will be in contact with you with the results, whether they are normal or if they're not normal. If they're not normal, we'll talk you through the next steps, which is generally notify your physician. And then also the next recommended step is usually a colonoscopy, but we'll talk about all that. This is not a test that says you have cancer. It generally is, and I've done several, probably a couple thousand of these now, and everyone that has come back positive, the the majority of them, I think it's 78% have had polyps. So that's the time that you want the polyps detected so they can be removed safely and not go on to be develop into cancer. Next slide. So the best test is the one that gets done. And next slide. You can see there my email address and my phone number. If you have additional questions, please take that down. I always get back to people, even though I'm on the road a lot, but I will get back to you within 24 hours with questions. Now I want to look in the chat room to see if we have any questions for any of the speakers. I don't see anything there. So it looks as if there aren't any questions from the audience. So therefore, I'm going to turn it back over to Joanne Boyd so she can wrap us up for this morning. Thank you for your attention.
Thank you, Lynn, and thank you all of our presenters. And of course, the partnership with Gateway Medical Society and Pittsburgh Black Nurses in Action is ongoing. It's been a great partnership to be able to share information through this forum. I thank our audience for taking time out of your day to allow yourself to get some new knowledge, perhaps, and hopefully you'll be able to take that knowledge and use it in your healthcare journey, whether or not you have cancer or know somebody that has cancer. You will be getting the Fit Kit as well as some informational literature that will come in the mail for all of those who are intended. So thank you and enjoy the rest of your afternoon.